Let's say, hypothetically, you're the medical director for a busy urban EMS system that's seeing rapidly increasing call volumes, most of which are low acuity. Now, let's defer a discussion of treat and place options here, and let's add into the scenario that you're having a difficult time hiring paramedics. You're looking at moving from an all ALS system to a tiered system with lots of BLS units. Those can handle the majority of the calls. You estimate around 60% of your call volume is BLS if you can take care of one ALS intervention. Now, because you're a nerd who overanalyzes everything, you look at all calls that got ALS interventions to see which the most common ones were. Now, as it turns out, after saline locks without fluids or medications, the most common ALS intervention is giving pain medication. Now, it occurs to you that if only there were a BLS intervention for pain, other than oral Tylenol, you could make better use of your BLS units and continue to safely relieve suffering. Now, because you work in this hypothetical scenario here, because you work in a delegated practice state, God bless Texas, you consider just making IV and IM opioids a BLS skill. Now, as you're considering this, your system director understandably is a little concerned about how much training time it will take to teach EMTs these new skills, and they worry about the logistic problems with controlling access to opioid medications on a much wider scale. All right, I get that. So maybe IV and IM opioids at the BLS level aren't the best thing. Next, you get really excited about adding methoxyflourane, the green whistle, to BLS units after you learned Australian lifeguards pretty much been doing this safely for years. And then your hopes are sadly dashed by nonsensical, stupid American regulations that deprive your patients of this seemingly magical drug. So you're left wondering if there was anything else that BLS providers could safely give for pain without requiring extensive training or stupid regulatory burdens. Now, stick around because I just read yet another paper from Dr. Sergey Motov's group that may have the answer to this problem for us.
What is a lighthouse? It is a tower with a bright light at the top, located in an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis, and I'm back with episode 84 of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of modern EMS clinical practice. You might have picked up on a hint that hypothetical scenario in the opening might not be all that hypothetical after all. And as it turns out, we're looking at options to better serve our community here in Fort Worth and our increasing volume of low acuity calls. More BLS units is one option that we're thinking about. I just read a few papers about nebulized ketamine, and it occurred to me that this might be what I'm looking for. If nebulized ketamine is as safe and as effective as IV sub-dissociative ketamine, it might be a good way to add effective analgesia to BLS units. So that might be a way to get these BLS units to be able to respond to a wider variety of calls. Specifically, I'm thinking about MVCs here without major injury. We end up with a lot of painful conditions from MVCs that get opioids, get some type of pain medication. And because of that, it gets triaged up to ALS units. But if BLS units had a good way of managing pain, this might be just the thing that we're looking for. These are big ifs, though. we need to first figure out, does it work as well as IV ketamine? So why don't we shine some of that bright light of science on this problem? What do you think? I think we ought to. First, though, I want to mention Sergei Motov, his group at Maimonides Medical Center in the Bronx. They have been doing some great work in the emergency analgesia space. First off, at least the first thing that I recall reading of his work is where he was showing how effective ketorolac was, and that 10 milligrams IV worked just as well as 15 or 30 milligrams. I then read one of his papers showing sub-dissociative ketamine at doses of 0.3 milligrams per kilogram was just as effective as 0.1 milligram per kilogram of IV morphine. Now, adding to that, in another paper, he showed that we could get all of the analgesia with much less of the dissociative dysphoria of ketamine by giving that ketamine slowly as an infusion over 15 to 30 minutes, as opposed to giving it as IV push. Well, he's now moved on to looking at nebulized ketamine. One of the first papers he did on this compared 3 dosing regimens of nebulized ketamine to try to find the right spot, and it looks like 0.75 milligrams per kilogram is the Cinderella zone. He really has been doing some wonderfully helpful work. Next up, another paper I want to point out is how did nebulized ketamine work in the field? Now, not great evidence here, but it comes from a place that I certainly know about, and by a doctor we know about, Dr. Casey Patrick, our friend who was at Harris County ESD 11 outside of Houston. He is now at Montgomery County Hospital District EMS. Those are the folks with the great MCHD podcast. If you haven't heard it, shame on you. You really probably should. Well, Casey, from his ESD 11 days, published a case series of the first 7 patients that were treated with a nebulized ketamine protocol. Now, they used to nebulize this, they used this thing called a breath-actuated nebulizer, or BAN, and they would give 1 milligram per kilogram of ketamine. Now, the BAN part is important here. We're not talking about traditional small volume nebulizers. BANs have a mechanism in them that will only allow the nebulized medication to release when the patient is inhaling. This increases delivery to the patient, and this part is important, while decreasing exposure to clinicians. There's a little valve in there. When you inhale, it opens up, the bubbly stuff comes in to the patient. As you're exhaling or no longer inhaling, the mechanism comes down, no more bubbly stuff comes out. I emailed Dr. Patrick. He said they haven't really seen any inadvertent exposure issues, and that's reassuring to me. Now, if you want to see what we're talking about here, you're going to have to do the same thing I did. I just went and Googled it. There's a brand name for one of these things called the Aero Eclipse. You can probably Google that. Now, to be clear, this is the first time I've ever seen this device, and I certainly don't have any conflicts in discussing it. I've never used it. Casey seems to think it works well. But there may be other options that work just as well. The key part is that we're not talking about small volume nebulizers. We're not talking about the things that your patient uses to use albuterol or Atrovent. Now, to be clear, this was a case series. You really shouldn't draw a whole lot of conclusions from it, and that's the reason I'm not going to get into a lot of detail. But it was the first thing that I'd really seen about nebulizing ketamine. It seems to be promising. So let's get to the paper that I really want to talk about. It's by Tommy Nguyen and his colleagues at Maimonides. Dr. Motov was the senior author, so this is the same group. The title is Comparison of Nebulized Ketamine to Intravenous Subdissociative Ketamine for Treating Acute Painful Conditions in the Emergency Department, a prospective, randomized, double-blind, double-dummy controlled trial. Great description there. This was published online May 2nd of this year in Annals of Emergency Medicine. Truly hot off the presses. Doesn't even have page numbers yet. Now, this is a well-done paper. It's pretty straightforward. There are no fancy statistics needed, and the methods are really pretty easy to understand. So let's get into it by looking at those methods, and then we'll hit the PICO question. Now, the study was done at a single academic emergency department in the Bronx, and as the title implies, this was a double-blind, double-dummy RCT. Now, let's break that down, especially the double-dummy part, because they're not insulting the people in the ER. The double-blind part, that means that neither the patient nor the clinicians know which drug is being given. That's good. Doesn't influence their rating of pain, either by the patient or by the clinician. Now, double dummy. That means that every patient is getting both the treatment and a placebo. In this particular context, patients got an IV infusion and a nebulized treatment of both. Now, they either got IV ketamine and placebo neb or IV placebo and ketamine neb. That way, they didn't know whether they were getting ketamine through their IV or through the nebulizer, but everybody knew they were getting ketamine. The only person who knew which drug was which and which was given through which route was the ED pharmacist who mixed up the study drug. Now, as an aside, I love ED pharmacist. The ED pharmacist in this trial would hand off, they'd mix up the drug, and they would mix it up in unlabeled IV bags or unlabeled medicine for the nebulizer. They would hand that to a study coordinator who would not know what was in either one of them, just know the number to label them with. And then they would hand that off to a nurse who also didn't know what was in the drug. Now, RCT, well, you know what an RCT means. Patients are randomized into which route they get the active drug. This is done to optimize the distribution of patients and minimize selection bias. Now, we've talked a lot about minimizing selection bias and why that's important, particularly in episode 79, where we talked about heads-up CPR. Now, speaking of heads-up CPR, if y'all will allow me just one moment of blatant self-promotion here. We just published an editorial about heads-up CPR in pre-hospital emergency care. Check it out for a more detailed discussion of why controlling for unintentional bias is important. And I really have to thank my co-authors on that editorial, Doctors Michael Sayre, Rimley Crow, Jim Menegazzi, and Henry Wang. It was a tremendous honor, privilege, and honestly, a lot of fun to work with these incredible scientists, all of whom I have learned so much from. All right, back to our paper. Those are the general methods. Let's get into the PICO question. So, population. They enrolled adults 18 or over who presented to the emergency department with acute pain, pretty much any etiology, and had an initial pain score of 5 or higher on that 0 to 10 scale. They included both traumatic and non-traumatic pain. Now, patients were excluded if they had altered mental status in any way, if they had respiratory distress that might make it difficult for them to use the self-actuated BAM device or BAN device. They also excluded them if they had abnormal vital signs. Patients had to be able to give informed consent. And finally, they couldn't be from a protected class. You know, the usual subjects here: prisoners, pediatric patients, pregnant women, the Ps. Patients were enrolled by research coordinators between October 21 and September of 23, Monday through Friday, 8 a.m. to 8 p.m. In other words, a convenient sample based on when the research coordinators were available. Now, this obviously raises a concern that maybe those patients who present in evenings and on weekends are somehow different than those that present during the day and during the week. Just one of the limitations of the paper. The intervention and comparison group. So patients were randomized by doing the whole computer allocation thing into blocks of 10 into one of the following two groups. So group 1, this is the IV ketamine group, they got 0.3 milligrams per kilogram of ketamine mixed in 100 milliliters, normal saline, that was run in over about 15 minutes. Then they also got 5 milliliters of normal saline that was nebulized through the band over 5 to 15 minutes. Now, group 2, this was the band group, the ketamine band group. They got 100 milliliters of normal saline infused over 15 minutes, and 0.75 milligrams per kilogram of ketamine mixed in 5 milliliters of normal saline nebulized over 5 to 15 minutes. Now, why the different doses? It's because of bioavailability. In their prior work, they determined that 0.75 milligrams per kilogram of ketamine nebulization inhaled gives you about the same effect as 0.3 milligrams per kilogram of ketamine IV. The primary outcome was the between group difference in pain scores at 30 minutes. Now, honestly, this seems like an odd choice of a primary outcome to me. I mean, it's okay, it's fine, but it's not what I would have gone with. And the way they described it in the paper confused me. Now, because patients are randomized to treatment groups in this type of trial, we're going to assume, with a fair amount of emphasis on maybe some hope, that patients will be randomized into two groups and end up with similar initial pain scores in both groups. And as it turns out in this paper, they did, and we're lucky for that. So this isn't an unreasonable primary outcome, but if there happened to be baseline differences in pain scores, this would have biased the results since they were depending on absolute differences in 95% confidence intervals instead of using some type of model that adjusts for initial pain score. They're just using the raw difference. I would have preferred to have seen the outcome as the proportion of patients in both groups that experienced a clinically meaningful reduction in pain scores. If not that, then maybe compare the amount of reduction between groups as another way of accounting for initial pain scores. Now, for full disclosure here, I may have misunderstood how they actually calculated change in pain score, and this is where I get to how this part was written being confusing to me. Now, they mention minimal clinically important changes in pain, and they use a previously validated 1.3 or more points on that 0 to 10 scale as an indicator for clinical meaningful improvement. So I think that's a reasonable thing. I think that's what they should have done. But the only place they mention that is in the context of discussing their power calculations and describing how they calculated how many patients they needed in both groups. Their tables, they reference raw pain scores at different time points. So I really think that this part is what they're doing. And they do the same thing in the prose section. And that's why I think they're just looking at raw numbers. Now, this uncertainty in how they calculated the intervention effect is my biggest question or maybe criticism of this paper. I definitely would have asked for clarification on this if I were one of their reviewers. Other than this area, this particular nitpicky thing, I really like this paper. Okay, enough nerdery, back to the outcomes. Their secondary outcomes included the need for rescue analgesia, meaning what they gave them wasn't working and they had to give them something else. And the something else in this trial was supposed to be morphine. Turns out there was an awful lot of docs winging it and giving something other than morphine. So the need for rescue analgesia, and they also calculated adverse events. Now, the adverse events, they broke down into serious adverse events, and that's what they considered anything that you had to do something about. So it's serious if you have to treat it. Now, they also reported on what I'm going to call ketamine-specific adverse events. You know, those things like dysphoria or dizziness that sometimes patients getting ketamine get. All right, on to the results. Overall, the baseline characteristics, including age, type of complaint, type of diagnosis, sex, age, initial vital signs, and initial pain scores, were similar between groups. That's what we expect from RCTs, and it's the whole reason we randomize. But still, it's nice to see that it works. Now, the most common reason for pain in both groups, as defined by both chief complaint and ED diagnosis, was abdominal pain. I found that interesting. Abdominal pain followed by flank pain, then traumatic and non-traumatic musculoskeletal patients or musculoskeletal pain. And when we're talking about non-traumatic musculoskeletal pain, I'm assuming we're talking about low back pain here, maybe throw in some arthritis, maybe some gout for good measure. Their power calculations said they need 67 patients in each group, and to account for loss of patients after enrollment, they aimed for 75 patients in both groups. And it turns out they were able to enroll those, so they ended up with a total of 150 patients. Their calculations said this would be enough patients to detect a difference of 1.3 points or more between the groups on those pain scales. So why 1.3? Remember, that's what prior studies have validated as the minimum clinically important difference in pain scores. Table 2 is the place to go to get the bottom line. The average pain score for each group, the difference between groups, and the 95% confidence interval around the difference. And it showed that at multiple time periods. Now, as a reminder, a 95% confidence interval with both the upper and lower limits on the same side of zero is an indication of statistical difference. In other words, if the 95% confidence interval includes zero, you got a negative number and a positive number, the difference is not significant. This is the preferred way of indicating statistical significance. At least it is with Annals of Emergency Medicine. And I got to tell you, I'm here for that. Down, I say, down with p-values. I think that'd be a great shirt, don't you? Down with p-values. Maybe throw in a EMS Lighthouse Project logo on there. I think I'm going to do that. Now, back to table 2. The primary outcome, remember, was the difference in pain score at 30 minutes. Now, because the 95% confidence interval included both positive and negative numbers, there was no significant difference. And in case this all sounds like a bunch of statistical fuckery, the average pain score was 3.6 with IV and 3.8 with nebulized ketamine. With that difference, just using my sniff test tells me that that's not really a big difference. So the statistical interpretation matches my clinical gestalt. Yeah, 0.2, not a difference. Interestingly, there does seem to be more pain relief with IV ketamine compared to nebulized ketamine when measured at 15 minutes, and that difference was statistically significant. At 15 minutes, the average pain score with IV was 2.6 compared to 3.8 with nebulized. That's a difference of 1.2 points favoring IV ketamine. Now, the confidence interval was between 0.12 and 2.24. That both on the side of zero, both saying there is a benefit. That means there is statistical significance. Now, this may be clinically important, but we can't say for sure. And let me explain that. The absolute difference of 1.2 that they saw at 15 minutes, well, that's less than the minimally clinically important difference of 1.3. Now, here's another but. The confidence interval includes 1.3. So what I'm really saying here is there's still a chance, if you don't mind me paraphrasing that great American philosophical movie, Dumb and Dumber. The bottom line here is there is no difference in their primary outcome, which is pain score at 30 minutes, equal drop. Now, y'all know I'm a sucker for a good data visualization, and this paper doesn't let us down. They give us a gorgeous waterfall plot in Figure 2. Now, I feel a great deal of sympathy for these authors because I think I know where that waterfall plot came from. I think it was a request from the methods editor. Now, I say this because that's how I ended up having to figure out how to make a waterfall plot in my DSI paper. And specifically on the how to do it, got to thank the statistician on that paper, Lauren Sager. She was able to figure out how to code that in R and teach me how to do it. But now that I've suffered through building one of those plots, I really like them, and I really sympathize with whoever up there in the Bronx had to code this thing. This figure, if you're wondering what a waterfall plot is, if you're not Joseph Zalkin, who I know has a thing for waterfall plots, if you're wondering what it means, well, it is a way to graphically show the difference between the first and final pain scores for every patient in both groups. And what you see is a line, and it just goes from the first to the last pain score, straight up and down, and the depth of that line indicates the amount of pain relief. Now, they also throw in some whisker plots to show the aggregate difference between both groups. I really do love these plots. This is one of those times as an author where the reviewer tells you to do something, and when you say, "Thank you for these kind suggestions, I truly, truly feel they improve the paper," this is one of those times you're actually being honest, as opposed to perhaps most of the other times. Secondary outcomes varied between the groups. There was more patients who needed rescue analgesia in the nebulized group. Now, while there was no difference in significant adverse events between the groups, there was more of what I'm going to call ketamine-specific adverse group events in the IV ketamine group. These are things like dysphoria or dizziness, a sensation of restlessness, or feelings of unreality. This suggests that the IV ketamine may have been more effective early on, but at the expense of more dysphoria when given by IV. But overall, there was no difference in effectiveness. So IV ketamine may be a little bit more effectiveness early, but overall, no difference. And there may be more adverse events, just the feelings of weirdness with IV. Now, the author's talking about that early difference and then no difference at the end point they were really looking at, the 30-minute part. They speculate that, maybe the nebulized group had less pain relief early because the patient is in charge of how to rapidly give the drug. Because remember, they are breathing in, and the rate they breathe determines how much drug they're going to get. So maybe they were breathing slower or just taking a hit, maybe not as often as somebody else. And that difference in administration may have made the difference. Maybe that seems reasonable. So what does this tell us, and why am I excited about this paper? Well, my takeaway is that nebulized ketamine is likely to be as effective as IV infusion, and with potentially fewer adverse dysphoric events. This means nebulized ketamine may be a promising solution to the question that I posed in the intro. Can BLS units effectively treat pain with nebulized ketamine? Overall, I think the answer is yes. I am seriously going to consider adding this to my EMT scope of practice here in Fort Worth. Now, obviously, I still need to take a look at the logistic implications of doing this, including how much that fancy little device cost. So it's not entirely a clinical decision, but we're going to give it a look. Because I think looking at this paper and others, I definitely see that nebulized ketamine can work. Now, because y'all listen to this podcast, I know that you're as big a nerd as I am. So I got to raise a question, or at least acknowledge a hardcore point of nerdery here before we go on. This was a trial that was designed to test for superiority. We can say from this trial that IV ketamine is not superior to nebulized ketamine. But as much as it pains me to point this out, failure to prove superiority is not the same thing as demonstrating non-inferiority. Now, if that sentence confuses the shit out of you, please join the club. As our former cigar-loving president said, I feel your pain. My friend, Dr. Ben Abo, calls me a savage statistician, and it took me a while to figure out what that meant. Savage here means that I understand statistics about as well as a caveman understands physics, just enough to start a fire and get the job done. In other words, I'm going to take the word of real statisticians who say lack of superiority doesn't equal non-inferiority. I'm also, a bit of a clinical pragmatist, and I think nebulized ketamine likely is non-inferior. It's probably just as good, even if I can't officially say that from a statistics standpoint. All right, guys, that's all I have for you today. It looks like nebulized ketamine is a reasonable alternative to IV ketamine for pain relief. You don't have to do the pokey thing, and you don't have to be able to do the pokey thing. In other words, this looks like it might be a good option for BLS providers. Now, please remember, as the final point, do not try this at home with a regular small volume nebulizer, unless that is you're really interested in getting a good hit of ketamine yourself. These breath-actuated nebulizers, they're different beast than the thing you use to give albuterol. As always, y'all, thank you for listening, and thank you for what you do every day. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast. a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.